Christopher. I'm sorry. I'm going to try to connect in an
Thank you, Cindy.
okay.
Hello all, I am Fadila Shaib, speaking to you from WHO headquarters in Geneva and welcoming you all to our global COVID-19 press conference today, Friday, 5th February. We have simultaneous interpretation in the 6 UN languages plus Portuguese and Hindi. I would like to introduce to you the WHO participant. Present in the room are the WHO Director General, Dr. Tedros, Dr. Mike Ryan, Executive Director, Health Emergencies, Dr. Maria von Kerkhoff, Technical Lead for COVID-19, Dr. Maria-Angela Shimau, Assistant Director General, Access to Medicines and Health Products, Dr. Sumya Swaminathan, Chief Scientist, Dr. Bruce Elward, Special Advisor to DG and Lead on ACT Accelerator, Dr. Kate O'Brien, Director, Immunization, Vaccines and Biologicals. Welcome all. Now, without further delay, I would like to hand over to Dr. Tedros for his opening remarks. Dr. Tedros, you have the floor.
Thank you, Fadila. Good morning, good afternoon, and good evening. Earlier this week, Captain Sir Tom Moore died with COVID-19. As you know, as he approached his 100th birthday last year, Captain Sir Tom decided he would try to raise £1,000 for the United Kingdom's National Health Services by completing 100 laps of his garden. He ended up raising more than £30 million. For me, Captain Sir Tom represents two things. The first is that everyone can make a difference, whether that's raising money, inspiring others, informing the public, or simply deciding to stay at home to keep others safe. The second is that Captain Sir Tom was a reminder of the value we should put on older people and everything they bring to our world. However, there is a disturbing narrative in some countries that it's okay if older people die. It's not okay. No one is dispensable. Every life is precious, regardless of age, gender, income, legal status, ethnicity, or anything else. And that's why it's so important that older people everywhere are prioritized for vaccination. Those most at risk of severe disease and death from COVID-19, including health workers and older people, must come first, and they must come first everywhere. Globally, the number of vaccinations has now overtaken the number of reported infections. In one sense, that's good news and a remarkable achievement in such a short time frame. But more than 3/4 of those vaccinations are in just 10 countries that account for almost 60% of global GDP. Almost 130 countries with 2.5 billion people are yet to administer a single dose. Some countries have already vaccinated large proportions of their population who are at lower risk of severe disease or death. All governments have an obligation to protect their own people. But once countries with vaccines have vaccinated their own health workers and older people, the best way to protect the rest of their own population is to share vaccines so other countries can do the same. That's because the longer it takes to vaccinate those most at risk everywhere, the more opportunity we give the virus to mutate and evade vaccines. In other words, unless we suppress the virus everywhere, we could end up back at square one. On Wednesday, COVAX published its forecast for the distribution of vaccines to participating countries. This is a very exciting moment. Countries are ready to go, but the vaccines aren't there. We need countries to share doses once they have finished vaccinating health workers and older people. But we also need a massive scale-up in production. Last week, Sanofi announced it would make its manufacturing infrastructure available to support production of the Pfizer-BioNTech vaccine. We call on other companies to follow this example. Companies can also issue non-exclusive licenses to allow other producers to manufacture their vaccine, a mechanism that has been used before to expand access to treatments for HIV and hepatitis C. The COVID-19 Technology Access Pool, or CTAP, enables the voluntary licensing of technologies in a non-exclusive and transparent way by providing a platform for developers to share knowledge, intellectual property, and data. This sharing of knowledge and data could enable immediate use of untapped production capacity and help build additional manufacturing bases, especially in Africa, Asia, and Latin America. Expanding production globally would also make poor countries less dependent on their donations from rich ones. These are unprecedented times, and we applaud those manufacturers that have pledged, for example, to sell their vaccines at cost. But manufacturers can do more. Having received substantial public funding, we encourage all manufacturers to share their data and technology to ensure global equitable access to vaccines. And we call on companies to share their dossiers with WHO faster and more fully than they have been doing, so we can review them for emergency use listing. Last Friday, we heard from health workers in Uganda and Pakistan who are waiting to be vaccinated. Today, we're pleased to be joined by 2 health workers from high-income countries who have been vaccinated. First, I would like to introduce Professor Gabriel Gold, who works in a geriatric department at the Troyes Hospital here in Geneva. Professor Gold, thank you for joining us. Please share with us your experience during the pandemic and your hopes for your work and indeed the world now you have been vaccinated. You have the floor.
Thank you very much for inviting me. I must say that vaccination for me was a huge relief. You mentioned the case of a centenarian who did so much and unfortunately suffered from the disease. It's important to remember that the sickest people with COVID-19 are very often the oldest and the most frail. I work in a hospital that has provided acute care to people with COVID-19, perhaps over 600 patients since the beginning of the pandemic. These people deserve top quality care for their COVID disease, but they also require a lot of help with other comorbid diseases, but most importantly, sometimes with very simple things. It can be helping them sit up in bed. It can be helping them wash their face or brush their teeth or taking a sip of water. It can be just a reassuring presence because sometimes they may be lost or confused because they are so sick in unknown surroundings. This means that there is a very close proximity when taking care of such patients between patients who have a very serious and infectious disease and healthcare workers. And of course, we use protection, whatever we need, the protective clothing and barriers and masks. But the vaccine is really a key way to prevent the spread of the disease. And of course, this is something that we worry about because we also have many other patients in the hospital who came in for other reasons, who don't have COVID-19 and we want them to be able to go home without COVID-19. So we want to make sure that we do not transmit this to them. It also reassures us when we go home and we have our families, close ones, because we want to be careful too about transmitting the disease there. And vaccination is also an opportunity for health authorities to recognize the immense dedication that healthcare workers all over the world have put in to provide care for people with COVID-19. Long hours, foregoing vacation, month after month, and probably for many months to come. The health workers are there as long as they are healthy. And vaccination is a way for healthcare authorities to first show their appreciation of these healthcare workers, but also their understanding that if you want to provide care to people who really are very sick and need it, you need trained healthcare personnel. They have to be healthy, and vaccination is an important way to deal with that. Vaccination enhances the motivation of people who have worked very hard and need to continue to work very hard to deal with this terrible pandemic. The pandemic occurs all over the world. People are getting sick all over the world. People need healthcare workers all over the world. They need healthy healthcare workers all over the world. So we should vaccinate those people who are at risk so that we don't fill the hospitals and the care centers with as many patients. And we need to vaccinate, of course, wherever they are, all over the world, healthcare workers who are providing this care. Thank you.
Merci beaucoup, Professor Gold. Thank you so much, and I welcome your support to accelerate vaccine rollout globally. Now to our second guest, Cindy Fras. Cindy Fras is a mental health specialist nurse at the Hospital Clinic of Barcelona. Cindy, we look forward to hearing about your experience working on mental health during the pandemic and what it has been like for you to be vaccinated. You have the floor, Cindy.
Thank you very much for the invitation and for the introduction. Good afternoon, good morning, and good night around the world. Effectively, my name is Cindy Frias, and I'm a mental health specialist nurse. And I'm mental health nurse at Hospital Clinic of Barcelona, the Child Psychiatry Unit. And today I'm here for explain my experience in this pandemic situation and all the vaccination process. Owing to this public health emergency, Spanish hospital, and especially my hospital, the hospital clinic, had to adapt, a lot of measures that include the adaptation, reorganization of clinical care units, hospitalization units, and even psychiatry units. All this change, was a pressure and challenges for the nurse and all the healthcare workers. This experience and this current pandemic has caused an important impact on our emotional well-being, from the beginning and until now, because for the unexpected, outbreak of the situation, the high rates transmission. Likewise, the increase of activity, the lack of staff, especially the nursing staff, led to an increase of our working hours every day. And that represented an important increase of stressor, for us. Even now, I'm suffering these circumstances, For the other hand, regarding to the direct contact with our patient, the measures and the nurse have had to reduce, or limit the nursing care. The nurse has had to reduce the time less in every visit to the inside the patient rooms. We have had to use personal protective equipment, for protection, and maybe this measure has caused in the nurse, and to express the feelings of fear, anger, and the sensation of less humanized care, no, and lower quality of care. Added to this situation, no, the hospital restricted or limited the family visits and the outside patient walks, no, and for that reasons, that measures affected the emotional well-being patient, no, the patient emotional well-being and the families too. However, I think it's very important to highlight, the adaptability, the cope of all the nurse and the all healthcare workers, the resilience, the capacity of individuals to bounce back or cope in this new situation, despite adverse circumstances. And can be the resilience and the capacity of adaptation of this health situation. It's important to can be understood as a process. That positive adaptation. To stress and adversity. In my case, I think I also adapt, to the situation as much as most people. Or as most my co-workers, but I have felt fear and anxiety because, for example, I have a 3-year-old son and I live with my mom, and I have especially been afraid of infecting them, and I have to come to work every day, and for that reason, I think I was feeling that sensation or negative thoughts every day, around the world, a lot of nurses have been infected, and many of them have died, and a lot of them were young. For example, I would like to share with you my own experience, because my own died in August from coronavirus disease, and she was a nurse. She was an extraordinary nurse, and she was only 51 years old. In fact, I'm a nurse for her, because she was my role model, and she was, repeat, an excellent nurse, and I always remember her as the best nurse in the whole world, and she infected while she was working, and she died quickly because she had a comorbidity, and she died a few weeks after the infection. She was a situation very, very deep for me, and obviously this loss increased my fear, my anguish, my anxiety, especially my mom. Therefore, I live this vaccination process like a great change, the enormous scientific advances in relation for my work, and I think it's fundamental, I received the COVID vaccine. I received the first dose on January 9th and the second on January 30th. And I haven't had any side effects, just a local pain in the arm. But some co-workers have experienced some side effects, minor side effects. Anyway, I have lived the vaccination experience as a lie of hope, a lie on the road. I don't know if this is the right explication, or the right. I did a translation, of my feelings, and I see the process as reliable, considering some negative aspects, but I think the vaccination process is is hope, no? Is hope, is faith in the healthcare system. And I think it's vital that healthcare workers around the world are vaccinated, because we need to do our work with, with security, no? With confidence, and we need to confident with the healthcare system, no? Uh, my family are very happy. My mom is happier for me, and my family is happy and hopeful for the future, and see the vaccination, no, the vaccination process, the COVID vaccine, as something safe, no, close, and maybe as a tangible fact, no. And I think the most of my coworkers see the vaccination process as something very positive, no, for us. And I think is we need this vaccine for all the healthcare workers around the world. Thank you so much.
Thank you, Cindy. Muchas gracias. We know many people have felt isolated during the pandemic, and the work you do as a mental health nurse specialist is so critical. Thank you once again to both our guests today. We're glad both of you have been vaccinated and are able to keep doing your essential work. And thank you to both of you for the clear call you have issued for health workers everywhere to be vaccinated. Fadila, back to you.
Thank you, Dr. Tedros, and to our guest. I will now open the floor to questions from journalists, reminding you that you need to raise your hand using the raise your hand icon in order to get in the queue. First question goes to Shoko from NHK. Shoko, can you hear me?
Hi, Fadila, can you hear me?
Yes, very well. Go ahead, please.
Yeah, thank you for taking my question. So COVAX announced 2 days ago its interim distribution forecast for the first half of the year, predicting its distribution to 145 economies. I do understand COVAX prioritizes, first of all, countries which aren't able to buy doses by themselves. On the other hand, I see some of the richest countries, such as Canada, is expecting to receive doses in the first half of the year. I'm not trying to blame any specific country for receiving doses, but why doesn't COVAX prioritize the economies which need doses the most? Thank you.
Thank you, Shoko. Dr. Swaminathan?
Yes, thank you very much for that question. As you know, COVAX was set up as a mechanism to provide equity in vaccine distribution across countries of all types, high income, middle income, low income. It wasn't meant to only serve low income countries. And as you know, there are two types of countries participating in COVAX: the self-financing countries, which pay in advance, make an advance commitment and then pay for the vaccines, and then the AMC countries, 92 of them, that get very subsidized or free vaccine. So it was also not clear at the beginning, when the mechanism was designed, that there would be so many bilateral deals. So the idea was that there should be a global mechanism that is able to procure at the best possible price, have access to the widest range of vaccine candidates, and then be able to distribute them globally based on the fair allocation mechanism that we set up, WHO set up with partners. Over the last few months, of course, things changed, and many countries went ahead and did bilateral deals and have their own supplies. But the COVAX facility is not going to penalize countries for doing that. However, in the first wave of allocations, we are looking at whether countries have started vaccinating already or not. And those countries, the DG mentioned 130 countries have not got a single dose of vaccine. So there is a prioritization, particularly for the early doses that are being shipped out in February and March for countries which do not have any vaccines at all. There's also the option for countries to opt out. So countries that have got vaccines through other sources, can opt out at any time of receiving, so that those doses can then be reallocated to the other countries which may not have access to anything. So it was set up to be a very fair mechanism. Things have changed over the last few months, but we still want to stick to the original principles that we based it on. Thank you. I don't know if Dr. Aylward or Samar want to come in.
Thank you. I would like now to invite Helen Branswell from STAT to ask the next question. Helen, can you hear me?
Yes, thank you, Fidel. Hello to you all. During your opening remarks this morning, Dr. Tedros, you mentioned that the WHO would like companies to start sharing their dossiers faster to get emergency listings through WHO. Can you give us a sense of who has done it and who isn't coming to WHO to get an emergency listing fast enough? Thank you.
Thank you, Helen. Dr. Simao will take this question.
Thank you, Helen. That's a very good question. And the call is, the WHO has launched what we call an expression of interest for companies to submit their dossiers, phase 2B and phase 3 only, to WHO. October last year, we received 15 submissions, 13 that were considered eligible. We do have issued one, which was the Pfizer, and we have 4 vaccine candidates in very advanced stage. And what I'm going to tell you now is public. You can find it on WHO's website. It's updated weekly. The stage of the assessment of each of these vaccine candidates is on WHO's website. So we have at a very advanced stage already the 2 Chinese manufacturers, Sinopharm and Sinovac. We have a team of inspectors in China since the 2nd week of January. They're waiting the quarantine to finish, and they will start inspections next week. We have 2 vaccines that we should have a decision on the 15th of January, which are 2 AZ-derived vaccines. One is the Serum Institute of India, and the other one is the SK Bio in Korea, which are vaccine producers that will provide to the COVAX facility. So we'll have a decision now. What we want is that those vaccines, those vaccine manufacturers that have more advanced vaccine candidates finalizing phase 2B or phase 3 trials to come to the WHO emergency use listing. And why is this important? Because the WHO pre-qualification of vaccines exists already since 1986. So it's not a new product, it's not a new service that WHO does, and it has pre-qualified 160 vaccines throughout all these years, and this facilitates 2 things. First, the UN procurement by UNICEF and PAHO, and second, it facilitates what we call the reliance mechanism. It facilitates that countries that do not have a strong experience in assessing vaccines because they don't